Good morning from sunny, dark Miami. This is Dr. John Bennett of Neurosurgical TV in the continuing collaboration with Deepak Gupta of the Department of Neurosurgery at the AIIMS Hospital in New Delhi on a conference on pediatric neurosurgery. And today we have the pleasure of having Dwarakanath Srinivas, a pediatric neurosurgeon from India, who was nice enough to volunteer his time. Let me introduce the guest first before turning it over to Doc. Hello, Dr. Gupta.
Hello, John. Thank you very much, and Dr. Dwarakanath, thank you very much for joining this platform. And I'm very excited to join, and I look forward to your talk.
Thank you.
Okay, very good.
So what I'll be doing is I'll be talking on syndromic craniosynostosis, and what I'll be doing is I'll just show you a few common syndromes and then discuss how to manage it surgically. Craniosynostosis, if you actually go back into ancient history, you will see lots of funny looking characters and you start wondering whether they really had craniosynostosis or were their heads remodeled like that. And there has been a practice of wrapping the skulls of infants and altering the head shape to be more egg-like than rounded. And it has been used by many cultures to produce a cosmetically pleasing effect. But of course, we cannot say all craniosynostosis are cosmetically pleasing, otherwise they won't come to us for treatment. So the relation was first established in 1791, that's almost 200 years old, where the relationship between the suture growth and the cranial shift was first noted by Sommering. And an important breakthrough came by Bischoff in 1851, described how the skull growth is restricted to a plane perpendicular to the affected suture and is enhanced in a plane parallel to it. And there have been multiple procedures going on over a period of time, but rightly Tessier has been called the father of modern craniofacial surgery because the first successful and the good results consistently came when Tessier started operating on these patients. And craniosynostosis needs to be differentiated from cranial dysmorphia. And cranial synostosis is one of the several causes of cranial dysmorphia. The Bischoff's law, like I mentioned, says that the sutures allow growth perpendicular to them. And whenever a suture fuses prematurely, the growth occurs perpendicular to the fused sutures and allows compensatory growth at the open sutures. And this results in an abnormal skull shape. Just before I go into the craniosynostosis, I'd just like to mention that the brain development at term, the child has nearly 40% or approximately that amount of his brain volume, which increases to 80% by 3 years, and the child brain achieves complete maturity at around 12 years. So you see the brain growth continues to happen after birth, and this plays an important role in the molding and cosmesis of craniosynostosis. So the growth is in a cranial pattern, and like I mentioned, the facial growth is not consistent throughout. While the initial okay. So the various disorders being described are the FGFR1, the TWIST1 genes, the MSX2 in Boston types, the FNB1 in the craniofrontonasal syndrome. So these are all the various signaling molecules which have been described, and probably the importance would be in translational approaches in which you can use gene-based therapy for management of these syndromes. But genetic non-syndromic also have been found genetic variations like the FGR mutations in the coronal sutures, but these are very small and by far account for less than 2-3% of the mutations. So while non-syndromic do have mutations, by far the most common causes of mutations are found in the syndromic craniosynostosis. Coming to the major syndromic craniosynostosis, the first would be the Cruzens, which is by far the most common of the syndromic craniosynostosis. It has mutations in the FGFR2 growth receptor and has an autosomal dominant inheritance pattern. The main skull anomalies described have been the brachycephaly, the scaphocephaly, trigonocephaly, and the children have a normal intellect. But apart from that, the other facial anomalies have been described in Cruzens. This is one of the Cruzens which are operated where you can see the various anomalies where there's an exorbitism, that is the shortening of the orbit which causes the eyes to be proptosed. That is midface hypoplasia, which causes the midface to be gone back. There's an anterior open bite, hypertelorism, beak nose, and there is no commonly reported limb anomalies in Cruisens. I'll be coming to when we compare it with APERTs. But the child importantly has a normal intelligence, and though they could also have associated features like conductive hearing deficits, strabismus, and hydrocephalus. Like I mentioned, the intracranial anomalies also which could be associated with hydrocephalus carry one malformation, hydroid herniation, and it's important to remember that because of all these intracranial anomalies, Cruisens have a higher risk of elevated intracranial pressure than other forms of syndromic craniosynostosis. While in one study they have demonstrated almost a 65% incidence of elevated intracranial pressure. Coming to the APERTs, APERT often has been described as Cruisens with hand involvement. While it holds to a certain extent, it's not exactly true. The mutations are in the FGFR2. It also has an autosomal dominant inheritance pattern, but it's much rarer. In the comparison between Cruisens and APERTs, the Cruisens there's an earlier closure of the lambdoid and sagittal sutures, 6 months versus 51 months, and sagittal sutures 21 months versus 60 months. And the incidence of Chiari-1 malformation is much higher in Cruisens than in APERT syndrome. The clinical features of APERTs are taribrachycephaly, the most common being the bicoronal synostosis. They have a very characteristic large anterior fontanelle. Like this is the anterior fontanelle, which is characteristically open and wide. They have a bitemporal widening with occipital flattening, and they frequently have a much severe midface hypoplasia than Cruisens patients. But the most pathognomonic feature of APERT syndrome has been the fusion of the second, third, and the fourth fingers. This is classically seen over here where the fingers are fused. The thumb might be free, but it is broad and deviates radially. In the feet, it usually involves the second, third, and the fourth digits. Like these are the feet. You can see the toes are fused, and they're so severe that they usually require surgical correction. The other clinical features are that the child has a varying intellect, but 50% have intellectual anomalies. They have cervical vertebral anomalies, but hydrocephalus is rare. Acne vulgaris characteristically develops during adolescence in over 70% of the patients, and characteristic nasal deformities resulting in apparent beak deformity occurs in syndromic craniosynostosis. While some studies have described that raised ICP occurs in 83% of the patients, while 50% occur in the first year of life, there have been some series which describe a far lesser incidence of raised ICP in APERT syndrome. The third most common syndrome would be the PFEIFFER syndrome. This is one of the PFEIFFERs which we had operated, which involves mutations again in the FGFR2 gene, and the inheritance is autosomal dominant. There have been various grades of PFEIFFER syndrome described by Cohen, who's classified them into 3 parts. One would be the type 1, which is the classical PFEIFFER syndrome, which is seen in 61%. The type 2 is more severe and associated with the Klibat schedule, which is the cloverleaf skull, which is seen in 25%. And type 3, which is the most commonly affected, which is the most severely affected, seen in around 14% of the patients. The clinical features ranges in severity from mild to severe. Ranges from taribrachycephaly to midface hypoplasia to exorbitism to hypertelorism and class 3 malocclusion, strabismus and down-slanting palpable fissures. These are the patients. You can see the down-slanting palpable fissures over here. The exorbitism, you can see the eye, the brachycephaly, which can be easily made out. There are varying soft tissue anomalies like broad thumbs, broad great toes. There is no fusion. Again, it's important to remember that all these 3 syndromes, intelligence is usually normal, but they do have associated systemic symptoms like oral atresia and conductive hearing loss in almost 80% of the patients. Hydrocephalus seen in 70%, and Chiari malformations also seen in 80% of the patients. The other syndromes which are much rarer are Sathry-Kotzen syndrome, which has an autosomal dominant with mutations in the twist1 gene. And the clinical features are a heterologous pattern of craniosynostosis again a microsynostosis with brachycephaly. They have a low frontal hairline, eyelid ptosis, facial asymmetry, ear deformities with a characteristic prominent crus helicis, and minority only have a hearing loss. Midface hyperplasia is not a common feature of Saxon-Coxon syndrome. Mwenke syndrome is one which is the first report of a genetic mutation rather than a phenotypic description. The clinical features include craniosynostosis of the coronal sutures with significant variability in the presentation of craniosynostosis. Again, bicoronal craniosynostosis is the most common presentation for both sexes. And hearing loss is common. There's a developmental delay, and midface hypoplasia is not common. Point to remember in Mwenke syndrome is that most of these patients, after they've undergone childhood correction of craniosynostosis, frequently require reoperations for either elevated ICP or failure of the repair. The reason is not known, but Mwenke syndrome characteristically have a higher rate of failure in craniosynostosis surgery than any other syndrome. Carpenter syndromes are some of the more severe types. The autosomal recessive, there is syndactyly of the feet. The sagittal lambdoid sutures close first and results in a classic cloverleaf skull. So these are the common syndromes, and how do we go about clinically evaluating them? First, of course, is a detailed clinical history. A family history is very important. You should ask for abnormal head shapes or multiple systemic problems. Clinical examinations include a complete systemic examination, apart from the head, including rule out deafness, cardiac anomalies, etc. Look for the limb abnormalities. Most importantly, you have to look for raised ICP, which complicates almost 1/3 to 70% of the cases. And some centers have recommended ICP monitoring before surgery. The causes of raised ICP could be multiple, either due to abnormal venous drainage, or hydrocephalus, or respiratory obstructions, or Chiari malformations. Hydrocephalus is seen in around 4 to 18% of the patients, usually a communicating hydrocephalus, and the causes either could be cerebral maldevelopment with subsequent obstructions, abnormal circulations, venous outflow obstructions, Chiari malformations, and aqueductal stenosis. The respiratory anomalies are which usually manifest during sleep and are due to the midface malformations like maxillary hypoplasia, coronal stenosis, tonsillar hypertrophy, etc. And the management could either include use of nasal stents or nocturnal CPAP. But the most important was the child is added to the other difficulties encountered in these patients include abnormalities of palatal shape and movement, disordered dentition, dental malocclusion, nasogastric tube or gastrostomy, and vision. Vision is one of the most common, indications of urgent surgery, and occurred due to chronically raised ICP, which can lead to either papilledema and optic atrophy, or shallow orbits can lead to keratitis, or primary optic atrophy can occur from compression and traction of the optic nerve. And like I mentioned, these patients require early treatment. How do we go about investigating them? Of course, in the olden days, it used to be simple X-rays, which classically showed the harlequin eye. The copper beating of the skull is a good indicator of raised ICP, though it's not specific, but copper beating should be taken seriously and should be an indication for early surgery. Ultrasound, the transorbital ultrasound can be used to measure the optic nerve diameter. There have been studies which have measured nerve sheath diameters in patients with craniosynostosis. It is low sensitivity for detection of elevated ICP when compared to that of fundoscopy. The most promising investigation, non-invasive, has been VEP, which measures the latency time of the averaged response. And if there is a delay in wave latency, it means that there is a abnormality which indicates some sort of axonal injury and correlates with raised interclavicular. CT scan has been a standard for complete visualization of the skull and the cranial sutures. Detailed anatomy of the calvaria and the brain parenchyma. And MRI has been used to look at the brain structures, look at the improved definition of the intracranial soft tissue structures, look for Chiari, and identify possible sites of respiratory obstruction in the midface. An interesting thing is that ICP has been reported in many patients, and like I mentioned, Cruzen syndrome has the highest incidence of raised ICP, which occurs around 83%, while in oxycephaly it's around 58%, and APERS around 50%. While in other non-syndromic craniosynostosis, the incidence of raised ICP is very low, between around 7 to 15%. This is a study by Preop et al. Which shows whether papilledema alone can be used. Even though it's a very specific indicator for raised ICP, it is not sensitive in younger children less than 8 years. But 100% of children above 8 years with elevated ICP had papilledema, and 22% of children less than 8 years who had elevated ICP had papilledema. So this is a probably important confounding factor in using papilledema as an indicator of raised ICP. So how do we manage this? The principles of management are very simple. One is we have to normalize the deviated appearance and growth and function of the skull, and keep the sutures open till the brain growth is complete. This is because one is a cosmetic problem. The second thing is this brain growth occurs throughout childhood. It's important to make sure that we leave it space for the brain growth. It is more simpler in non-syndromic, but in syndromic craniosynostosis, management is much more common. And look for other intracranial anomalies, especially for carry-1 malformations. And you have to have a discussion with the pairing, the options management, whether they would like management. It has to be a true and frank discussion with the parents, and it's a multidisciplinary effort. So let us not delude ourselves thinking that we alone can do it. We have to take help from multiple specialties, like a plastic surgeon, especially craniofacial surgeon, an ophthalmologist, otolaryngologist, orthodontist, as psychologists, social worker, genetics has to be done. So all these fields have to be taken, and indications for surgery include correction of cosmetic abnormality, early management of intracranial hypertension, optimize the brain growth, severe proptosis and impending corneal damage are important indications. And the other important indications would be the psychological effect on both the parents and the children and his friends. Because kids are very sensitive and they do not realize when they are teasing other kids about their deformities. So it's very important that for the psychological outcome of the child, early surgery is done so the child returns to normal activity as soon as possible. In fact, we had one child with Cruzens whose friends used to keep on trying to poke his eye. And it used to become such a big problem that the parents came and used to cry that we need his cosmetic effect to be very good so the child can go have a normal activity. These are some of the few indications for surgery. So when do we operate? If the child has elevated ICP, we need to do it immediately. But if the child has normal ICP, when to do it is a question. There are different points to discuss, and these are always debatable topics. But points to remember is that in earlier age, bone is more malleable and easier to remodel. But below 3 months, it's very soft, so decontouring becomes unstable, and there's high incidence of failure. While in greater than 1 year, the ability to cranial base to respond to intracranial forces diminish. And with increasing age, skull deformation increases in severity and permanency. So what we generally do is a Calvarian infant between 3 to 12 months is much more malleable, easier to shape and providing a better outcome. Generally, most centers prefer surgery between 6 to 12 months. And early surgeries prefer to prevent the further progression of deformity, possible complications associated with the raised intracranial. So what are the basic principles? One is passive reshapement, like generalist removal of the bone, split craniectomy and morcellation. Active reshapement includes fronto-orbital advancement and cranial wall remodeling. And I will some of the important principles that use a stealth incision, which prevents parting of the hair along a straight line, looks more cosmetic. And I'll show you the diagrams later. Of course, the child needs a good preoperative evaluation, routine bloods. Syndromic includes blue-outs, obstructive apnea. What is the airway anatomy is important for using fiber optic intubations. Cure any sort of upper respiratory tract infection, especially in fusels and inverts. Look for congenital heart deficits. Once all this clear, the patient can be taken up for surgery. So what are the current approaches nowadays? One is initial front orbital cranial wall remodeling has to be done in all patients. Previously, monobloc in that all the three procedures used to be done at the same time. Now it's not favored. Usually we go into the front orbital and cranial wall remodeling. Follow it up with the midface advancement with or without distraction when the child is around 4 to 6 years. And when the child reaches further around 12 to 14 years, going for secondary orthognathic surgery to correct any dentation. So the goals include, like I mentioned, increase intracranial volume, decrease the ICP, improve the head shape. The most commonly used are the cranial wall remodeling with or without with fronto-orbital advancement, while the other techniques used are cranial wall distraction, spring-assisted cranioplasty. So these are the steps in which you can see there's a frontal advancement, the orbital boundary is created, the frontal orbit is also advanced. This is a hypertelorism correction, where a strip of bone is removed and then the two orbits are brought together, which corrects the hypertelorism. These are some of the cases which I've done. This, of course, is not a craniosynostosis. This is not a syndromic, but I just mentioned the steps. You can see the stent incision over here, zigzag incision. This prevents parting of the hairline and saint line, so it's more cosmetic when a child grows up. The skin flap is elevated. Here the periosteal flap is elevated. I elevate the periosteal flap, but some people do not because they feel that there is more blood loss. I do not take it out of a single flap. I do it as multiple flaps. Make a burr hole on either side of the superior sagittal sinus. Do a bilateral frontal craniotomy. Remove the two bone flaps on either side, and then go in for a central bony flap, bony segment elevation. So this is how the brain looks after the craniotomy. Frontal, complete bifrontal craniotomy. So once the craniotomy is done, our target is the supraorbital bone. When an orbital bandeau is taken out, we use fine drills, dental drills is preferred. Then we remove the orbital bandeau over here. And then this is the hypertelorism correction, which is strip of bone has been removed and the two orbits have been brought together. This reduces the intercanthal distance. And then we do the remodeling of the facial of the front orbital bandeau, make it more shapely, use probably resorbable plates over here, and then the orbital bandeau is replaced. This is advanced using metal plates or resorbable plates depending upon the affordability of the patients. And you see approximately around 1.5 to 2 centimeters of the front orbit is brought forward. And once it is done, rigid fixation is used to fix the bone flaps together. Nowadays, we are using rigid fixations only for the anterior to keep it in place, and these have been replaced by sutures. And then the wound is sutured. These are some cases, the trigonocephaly which I have done. You can see the child after 4 or 5 years has got an excellent cosmetic results with the proptosis completely corrected. This is the same patient. This is a patient with Cousins disease, Cousins syndrome, operated. You can see again the proptosis has been corrected to a large extent. It is a large incision. Incision goes frequently posterior and the entire skin cap is taken. This is another Cousins. You can see the correction done over here. The proptosis has been corrected. This is one of a few unusual cases which we did in adolescent girl around 16 years old. This is the oldest patient which we have done. We're not very sure because the bone is not very osteogenic at this age. But we had to do because she was developing these visual field constrictions due to raised ICP. And we did a fronto-orbital advancement along with cranial remodeling. And this is the cosmetic result we got in which the orbit is brought forward and the proptosis has corrected to a large extent. And the visual symptoms have remained constant for a period of time. The other procedures followed are posterior wall remodeling, in which FOA is contraindicated or not possible for certain reasons. The advantages of posterior cranial vault expansion is that it provides a larger volume increase per millimeter of advancement than anterior expansions. And many patients with toric brachycephaly have a posterior flattening, which is an ideal target for extracranial vault remodeling without frontoorbital advancement. So posterior vault remodeling can be used exclusively if someone is not planning for a frontoorbital advancement, because posterior vault remodeling provides for a higher uh, volume increase. And of course, disadvantages are that there is increased blood loss. Limitations of frontoorbital advancement, of course, is not possible. And an important thing is, especially in children, is that you have to remember that when the child sleeps, that there's a propensity for relapse because of the weight of the child's head goes onto the suture lines, onto the plates and screws. So there could be a higher rate of failure. This is a comparo of the two types. While the anterior is more complex, you have to be more precise and orbital advancement is possible. Posterior is that there's simplicity of anatomy. It is more forgiving to surgical errors. The hair covers the irregularities. Chiari 1 can be corrected, and there are fewer critical aesthetic structures. But like I mentioned, that there's a greater risk of failure because the child when the child is sleeping. But the great advantage is that FOA can be delayed and it can be used as an acute procedure. To get over this, where posterior vault, instead of posterior vault, a single stage where a distractor is placed and distraction osteogenesis is done, where the advantages include maintenance of bone vascularity, production of vascularized bone occurs, there's a gradual expansion over a period of time, it allows for greater advances to be achieved and maintained, especially in the midface distraction, and it is advantageous in patients with severe toricocephaly and occipital flattening due to posterior expansion. Of course, distractions are that we are living in a country where infection rates are probably slightly higher. Needs for second procedure for device removal. So, the problem of infection always remains, and device-related complications can occur, and the treatment time is prolonged. But one interesting benefit is that the Chiari ones have been shown to improve with posterior vault distraction and posterior vault remodeling. The other controversial things have been spring-assisted cranioplasty. We don't use it. The surgeon has no control over the distance or rates of advancement, and the technique remains somewhat controversial, and it has been used mainly in sagittal suture synostosis. Monobloc procedures used to be used, in which the frontoorbital advancement, the midface advancement used to be done in a single sitting, but this had significant surgical morbidity and there's high blood loss, high rate of infections, and it is not used at present. What is preferred is staged midface advancement, in which, like I mentioned, the cranial advancements are done initially, and when the child reaches around 4 to 7 years, the midface is brought forward. The two methods have been used. One is a standard method in which a single stage. Second is, like what I mentioned, a distractor is placed. The advantage of distraction is it allows a correction over a period of time, and it can be much higher rates of distraction can be done while compared to standard methods. But of course, the the instrument-related complications are higher. This is an important point in a country like ours. But it has a better efficacy and improved safety profile, and allows for expansion of soft tissue envelope with bony advancement, decreasing relapse from soft tissue contraction. Like I mentioned, it's less blood loss, shorter operative time, greater advancement, more than 2 centimeters compared with standard techniques which are around less than about 1 centimeter. Elimination of bone grafts, reduced infection risk immediately, but higher infection risk. Second procedure to remove worry device is an important complication, and it requires an external halo device, and some patients find it very inconvenient. However, distraction osteogenesis has significantly improved the results obtained for midface advancement while minimizing the complications. Late intervention, like I mentioned, in adolescent patients has its own pitfalls because the adult cranium is less amenable for osteogenesis, and there's a higher risk of recurrent deformity, and surgical risk correction is more complex. In adolescents, probably it's just stage 3 where orthodontic surgery is done to correct the dental anomalies, and final facial contouring in which smoothing down irregularities, adding bone grafts or bone substitutes, and resuspending soft tissues is done in adolescent age groups. Every surgery has its own complications, including anesthesia-related complications, general complications. Specific include hypovolemic shock, which is an important factor, coagulopathic states, parenchymal injury, CSF leaks, intracranial hematomas, infections, all early complications. And long-term complications include wire and plate screw granulomas, temporal muscle detachment and temporal hollowing, unsightly bumps and lumps, and if they recur, resurgery might be offered to the patient, should be offered to the patient, and to give a good cosmetic results overall. Our results are on 76 patients over 8 years. The most common have been the non-syndromic varieties, especially the plagiocephaly and brachycephaly. I think it's important to mention that in a country like India, many patients do not prefer surgery for minor and moderate forms of craniosynostosis because they feel that the child looks okay. In India, we generally tend to correct more complex and more obviously unsightly craniosynostosis. Multisutural, we have operated on 12 cases. And to conclude, I'd just like to summarize that craniosynostosis is an eminently correctable condition, but you need to have proper diagnosis and management decisions. The most important being a multidisciplinary management with proper counseling regarding the surgery, the outcomes, the possibility of multiple procedures. But once properly done, it has a very good and satisfactory outcomes. And when we did our study on our patients, we got a smile grading of almost 8 to 9. So I'd like to thank my two colleagues, Dr. Dhaval Shukla, my colleague in the Department of Neurosurgery, and me who do most of the surgery, plus the advanced. Thank you.
Okay, very good, doctor. Thank you very much for taking the time to present a clear presentation. Deepak, do you have any comments?
No, I just want to congratulate Dwarakanath for an excellent presentation and covering almost anything and everything on syndromic craniosynostosis. Thank you, Dwarakanath, for a wonderful presentation. Thank you.
Thank you, Deepak. Thanks a lot.
Very good, doctor. This is the kind of, you get off the screen share, just click on the screen arrow. Take it off. Yeah, this is the kind of education I think might be good for pediatricians and outlying neurosurgeons. So, okay. I'd like to thank the doctor for taking the time, and I'll be sending you the link to this video.
Thank you, John. Thanks for the wonderful support you have provided us. And I think this whole thing would have been impossible without your help and guidance. And thanks for being patient with our internet in India, in Bangalore especially.
Okay, very good. Thank you.